Thank you, everyone. Thank you, PK, for letting us do this live case with me and Dr. Gujja together. And for the panel, thank you for staying. This is the last session. So from Mount Sinai, we would like to introduce, this is Karthik. Of course, you know him from our live cases. We have our fellows here, Twinkle and Luke. And we have Ray Lascano, our nurse practitioner, our two nurses, Mac and Jen, and we have Damien and Foster outside helping us as techs. So being an iliac intervention topic, so we, especially with alternate access, we presenting this case today about an iliac intervention through non-femoral approach. So Twinkle, can you present the history? Or Luke?
Yeah,
Luke,
sorry.
Go for it.
Please.
So if we can put the slides up. We have a very nice 82-year-old woman. She has the normal comorbidities and a history of multiple bilateral lower extremity interventions in the past at an outside facility. She unfortunately is coming to us with continued bilateral lifestyle limiting claudication with one block of walking, the left markedly worse than the right, despite maximal medical therapy and an exercise program. She did have an angiogram at the outside hospital that revealed a significant left iliac and, in addition, left CFA disease that was fairly significant. And she's on appropriate medical therapy. So we can go to the next slide. She had some non-invasive imaging as well that was suggestive of possible left iliac disease. She had reduced ABIs on both sides, with the left a little bit worse. And her labs, renal function, and hematocrit were all within normal values. And then we have one picture from the outside hospital angiogram that does show the significant osteal left common iliac lesion that we're here to deal with today, with the idea of getting her fixing the inflow and getting her potentially to a common femoral endarterectomy in the future.
Right. So good, thanks. So just to add on, so the reason they identified all the left-sided disease because they went and fixed the right SFA. So you're going to see pictures when Karthik discusses the angiogram. So the right side was intervened, did fine, but left side is mainly what the problem is. So Karthik, can you just show us some pictures so we can decide?
Yeah. So we took the angiogram as we decided because of the left significant CFA calcification and disease. We decided to use an alternate. We can't go from the right because of the osteal left common iliac calcification disease. So we choose the radial axis. So for this, we use the 7 French because it's very calcified, and we felt like we might have some need for further other therapies which might need a 7 French device. So we use a 7 French sheet here. And her radial artery was pretty good in size. We actually checked it with the ultrasound. It was about 3.5. So it was pretty big size for to get in a radial 7 French access sheet. So we got a 7 long sheet close to the bifurcation. We're taking pictures. We took the shot just to show the scout is completely calcified iota with bilateral common iliacs. So you can calcified. So you can see the very eccentric calcified lesion in the left common iliac, and you can see at the bottom of the image how much amount of calcification there is in the left common femoral artery. So at this point, I think it's Vishal's patient. So I think he decided that should probably be dealt with the common femoral endarterectomy. So we thought we will fix the left common iliac first to fix the inflow, so the patient can proceed for the left common endarterectomy. So that's Karthik, the plan, at least as of now.
But look
Karthik,
at
just a question. Yes. Just a question. I know the panel is thinking the same thing. Is that 7 French in the radial? I mean, that's which sheet did you choose? Yes. And tell me about the sheet. And what did you guys do to prevent or at least minimize spasm? As George said, the spasm is a big problem.
Okay. So yes, first of all, before we choose a 7 French, we actually measured the radial artery. We were going with R2P, but we only decided with 7 French because the radial artery size was more than 3. So I personally feel, I think the radial artery sizes when we do for coronaries have clearly shown that any radial artery size more than 3, radial artery occlusions are less. If it's more than 3, you can accommodate a 6-7 or a 7 French sheetless device. So we went with the 7 French sheet Cook sheet, which was a Cook sheet here, so that we can accommodate it nicely. And there was a nice, there's a nice coating on it, hydrophilic coating, so the transition is great. So it was a very smooth transition. We dilated first with the 6 French dilator, and then we put in, we actually gave when we got the access, we put in a 6 French sheath in, short sheath in. We gave the cocktails as we normally do. We gave the verapamil and nitro through it. And once we put the long sheath in, we put a layer of nitro paste on the 7 French access site, just so that the patient doesn't get any spasm locally.
Well,
Right.
those are good
And
things.
also, we want to make sure, like
Vishal,
like
one
George
thing.
said, sedation. So she's very well sedated.
Yes, speak.
Right. So, Vishal, one thing, and Karthik, I mean, you have Dr. Jenkins here, Dr. Atanti here, who do a ton of radios. I'm sure Eric also.
Yes.
I mean,
yes.
and George. So, Dr. Jenkins, I mean, you've been doing radios since probably before I was born. So, I'm just curious in terms of as my teacher, what do you think about the 7 French sheath in the radios?
Actually, you were wearing diapers.
Yeah, that's true, Dr. Jenkins. He's just trying to say that you're pretty healthy. I mean, you still run a marathon, so it's okay.
No, so you have to know that I learned on Sohn's technique at University of Missouri in Columbia. And so we did brachials there. And when I moved to New Orleans and went to work at Ochsner, Chris White and Steve Ramey looked at me doing a brachial artery percutaneous puncture one time and said, "What the F are you doing?" I said,
Damien?
I'm using it because you can. But I want to know where you got the data for measuring the renal artery to determine what size sheath you can put in a radial artery. And number 2, there is a brachial artery. You shouldn't be scared of that. And number 3, there's also an axillary artery. You can get radial access with a proper size sheath. You can look at the lateral thoracic artery, put a wire down it, and you can angiographically stick an axillary and close it easily with. I'm not condoning doing that, but I'm saying if you want to get big equipment like George was talking about, distally, there's also the axillary artery if you're an interventionalist, and arteries and arteries and artery, and you can find other accesses. I mean, this is the day and age that you do what you need for what you.
And you can close the axillary artery.
So you can close that, but
I
you shouldn't.
I agree with
Dr.
Dr. Jenkins. I guess the biggest question is.
All right. Yes, go ahead, Michelle.
Oh, so I guess the biggest thing is, I mean, we have, like you said, we have the brachial artery, the axillary artery, but there are complications associated with the brachial and dealing with them. I guess it becomes a little bit more complicated as compared to radial artery. So brachial, getting hemostasis, pseudo, there's no bone there. Axillary, you have to make sure there's good perclose. If you fail, you have to put a covered stent. Radial, if it's healthy, can I get the ibis closer? Then even if there's a little bit trauma, and like Karthik said, if the vessel size was good enough and not enough calcification, can accommodate a 7 French without much discomfort. Unless you feel resistance, then of course you have to start looking for other options.
So you guys are doing an IVUS now?
Yeah. So just to show you.
Okay, good. Well, 1 second, Vishal. When you do the IVUS, I just want to ask Srini, who does a ton of complex coronaries through radial as well. Srini, I mean, in terms of your large bore rotas and stuff like that you need to do with a 7 French sheath and guide, I mean, do you do radial or
yes?
What's your experience with 7 French in the radial?
7 French? No, pretty commonly.
Okay.
Especially we need atherectomy, rotablations.
Mm-hmm.
We do 7 French, especially in men, not a problem.
But she's a woman. She's an 80-year-old woman. Eric, yourself?
Do you measure the renal artery before you put a 7 French in the radial?
No.
We don't.
I think 7 will work
Jenkins,
fine
I was
in
trying to say
radius,
that
and I
we
don't
can
have any
accommodate a
problems with
radial.
that. 8 in a brachial.
Everybody?
Yeah.
Someone else.
My feeling is if you need an 8, brachial makes sense. If you need anything less than that, then I would do radial over brachial any day. And I would be surprised how often people can accommodate a 6 or 7 long, even a 7 long,
right,
irrespective of the measurement. So the key for me, though, is we do this all the time in the corner. I mean, we're about 90% radial, sedation up front. And then I use balloon-assisted tracking most of the time. So I'll put in a balloon in the sheath and bring it all the way down, even for peripherals. I'll bring it all the way around the bend and then put the dilator back in and bring the 119 to remote sheath down to the bifurcation. But I have never, I have to say, I'm much at a different stage of my career, but I've stuck brachial maybe twice in years.
Well, just a little history. When I was doing the brachials, they didn't even make 7
Exactly.
We only had 8s.
Yeah.
So I have a question, Dr. James, for Raj, who's operated, bailed me out a couple of brachials. Remember when I had my brachial dissections? So Raj, I mean, tell me a little bit about the radial. I mean, what do you think? I mean, are we being crazy by pushing it to these larger, more sheets, or what's your thoughts?
It's a tough question. You guys are more comfortable doing radial access than most vascular surgeons are. So that's what you guys do a lot of the time. So to me, it sounds large. I mean, I probably just use the brachial because we're very comfortable using the brachial, and that's our go-to. I think there are few vascular surgeons who have adopted some radial technology.
Yes.
But then again, there are quite a few limitations. So I think for that reason. But I think you guys are very comfortable doing it.
Okay.
Right.
It's been really hard to win people over.
The best
I've been in
part
battles
is-
on Twitter on this.
the
Yeah.
best
We
part-
can't wait for Twitter.
Yeah, you can look it up. Yeah.
So listen, what question for Peter? Peter,
Dr. Jenkins, if I knew you were on the panel, I would have probably put a 6 range.
Or
So, I mean, I think that the lack of equipment from a length perspective is preventing me from doing it. We have done a few, especially from a diagnostic perspective. But the lack of, for me, backup equipment, especially from a stenting perspective, really limits my use.
it's great points.
Maybe you shouldn't say this, but it doesn't matter if you destroy the radial artery.
No, we would never say
Well,
that.
one more
It
point.
doesn't matter if your Allen's test is abnormal or normal. You destroy the radial artery, even with an abnormal Allen's test. The hands typically still stay alive.
I'll push
If
it one
not,
more further,
You're a
though.
peripheral interventionist. You can fix it.
The ultrasound's useful, though. I'm not sure about the 3 millimeter mark, but sometimes the ulnar is the dominant vessel.
Yes.
And so I'll take the ulnar over a radial. It's no difference besides hemostasis. You have to be much more careful when you put your TR band on. But I take the dominant wrist vessel, peripheral or coronary, and I use the ultrasound for that.
Got it. So Karthik and Vishal, go ahead. You heard the discussion. Great discussion. Great
Right.
case. You brought up all the great points.
So
Why don't you show us the IVIS?
Right. So we're going to show you that. But just to put a point across, like Karthik said, usually we're used to the R2P shape, but in this case, we didn't choose the R2P shape because remember, we're thinking about trying to treat this calcified lesion by different modalities. And R2P is usually 119 centimeters. So let's say if you have to use a shockwave of any other devices, the shaft length is the biggest limiting factor. In this case, the lady being shorter actually sometimes works in our favor. So you can use a shorter lens sheath and still reach our distal aorta iliac and have more possibility of using other devices. So that was one of the reasons we didn't end up in an R2P in this case.
Yeah.
So
Okay, so
anyways, let me show you the IVIS right here.
please.
Prakash,
So we apply.
in terms of acting for the length limitation, like Dr. Jenkins says, we can use, now we're doing the alternative access for the towers, so the axillary percutaneous approach.
Right.
So which much more comfortable now, since we're doing the axillaries, to do the axillary, we can get length
Yeah.
further down to the feet. all the
Right,
way.
absolutely. No, but I think he's worried about the fact that the shockwave balloon or the covered stand or whatever he wants to use doesn't have the length. The sheath, he knows he has
The
plenty of
shockwave
length.
shaft length is 110.
Yeah,
PK.
so
So
I think
that's
he's
what that
worried
was our
about-
concern.
And we got to talk to our industry colleagues, make both Bard and Gore, please make longer length devices because, these cases are becoming more and more common, for us. But go ahead, Karthik. These are great
Correct.
points.
So yeah, I think as
One-
George was mentioning, we are limited to balloon and stent with radial technology.
Yeah,
So
You guys have a cook sheath down, correct? Is it the ansel?
yes,
Yeah.
yes.
So
Yeah,
why
yes.
choose a stiff sheath to go down?
So we have issues. We have an arch issue. So she had a big arch. So we needed something stiff to hold off so that the sheath doesn't move back and forth. Because we wanted to make sure that even by using a 190 centimeter sheath, our 110 shockwave, if we're going to show it to you, we're completely hopped on it. So we didn't want the shockwave to not reach it. We wanted to have a backup if you have to do anything about it. That's why.
Okay, let's go to the IVIS. I want to stay on time because everybody's long
right.
day.
So if you see the IVIS right here, we started from distal SFA just to show you how the CFA was bad as well. And Karthik will play for you. You can see the degree of calcification in the CFA. And there's an area, very focal, very tight area on right there. So CFA also has significant disease. And that was the biggest limiting factor of getting a left ipsilateral axis on the CFA side. So if you keep going forward, now this is the external, which looks good, lumen, disease-free. And then you're going to start seeing our common iliac come right there with that calcification. Look at that narrowing right there. The eccentricity of the calcification and the narrowing is very significant. And it reaches right at the ostium. And then so that's our distal aorta right there. So you can see suddenly it just shrinks back to pretty much 90 degrees of stenosis, or even more, I guess I would say.
Mm-hmm.
So that's our IVIS right there.
So what's your
keeping
plan?
in mind right. So me and Karthik discussed about it, and we talked to Ray as well. And the idea is there are no real atherectomy devices for iliac. Right as per guidelines, you're not fast to indication using atherectomy. And because shockwave is an up-and-coming technology, especially in calcified lesions, I think this patient would have been is a good candidate for shockwave therapy. And like I said, we had enough adequate length, it being right at the ostium or the proximal segment. So we actually have a shockwave ready to use it so that we get some luminal expansion. And then the idea hopefully is to use a covered stent to give it as a definitive therapy.
So Vishal, my question to you and Karthik is, how did you guys size the shockwave? Did you size it to the external iliac? Did you size it to the common iliac?
So we sized
How are you guys working on
we
this?
sized it to the external iliac, PK. So we took a 6.0 shockwave. We just wanted to get, even with our regular catheters, even with our 035 catheter, we were unable to get through with it without any resistance because of the amount of calcification. We just wanted to clear a path for us so that we can get a good expansion initially and get the balloon across, because even the regular 035 balloons are not passing through the lesion.
So
the idea is to just get some luminal gain.
So listen, you guys go ahead. I just want to ask the panel as you guys are shockwaving, and I think this is an important question for all of us too. So Eric, I'll send this to you because you know the cost of iliacs are so expensive in the sense that the reimbursement doesn't always match the amount we spend. So if you're going to plan on using a covered stent, right? Why don't you do this crack and pave technique versus shockwaving? Because, or pave and cracking. Shoot, take it backwards. Pave and crack.
Also,
rather than shockwaving, because then you can save yourself a lot of money. Is that something that you think makes sense, or do you feel comfortable in terms of dilating the lesion first?
Yeah, it's a great question, man. I don't think that approach is wrong. I think not all of us feel comfortable with that, and you also risk the fact that you just can't get that stent to grow, and then you're stuck with the underexpanded covered stent, which is everybody's nightmare. And we've tried to shockwave through covered stent before; it doesn't. Variable experience there with low numbers, but so I mean, again, I like the safest approach for a lesion like that. The rupture risk is reasonable here. You're only radial access. And I think a low pressure shockwave makes a lot of sense. And then, again, you do what's best for the patient minus the dollars. And so if the covered stent's the right, stent choice here, which I think it would be if it reaches, then, I think we put the finances aside. But it's a great question. I always worry with the crack, the pave and crack is if you just cannot get that stent to yield, you're stuck.
George, Raj, any thoughts?
Well, I was going to say that the hospital's going to make their money back on the femoral endorectomy. So it's downstream revenue.
Well, I'm saying before the shockwave, I guess that's.
So if you look at the balloon right there, there's still a waste on that 6.0
covered
balloon.
stent. So
So Vishal, we were just talking about paving and then cracking it, and most of the panel seems to think your approach is right, but I don't know. I guess I'm like Dr. Jenkins. I'm worried about where my tax dollars are going. Well, so I want to make sure.
The only reason we want, I just want to say about the pave and crack, right? So, the only reason we were worried about is about that right at the ostium, if you see.
Right.
So we were worried about that calcium chunk, not the calcium chunk which is actually down in the right where the ostium is. There's a big calcified plaque, eccentric plaque. We were worried about that. When we are cracking that open, I was more worried about that expansion than anything else.
Okay.
That's why we went in this path.
We just don't want the calcium to go the other way. So I guess with this technology available, I think it's reasonable to use it to give it an optimal, hopefully a safe and a good result.
Dr. Jenkins, you want to say something?
Yeah, I was just going to make a comment about if anybody knows any data about crack and pave or pave and crack, please tell me. But I can tell you not infrequently. And I was telling PK at the break of a patient who had a stent placed in a coronary for a STEMI transferred to me Sunday, and Monday with a 70% stenosis and a freshly placed stent with heavy calcium and an RCA, I easily get shockwave I ruptured with a high pressure inflator. I ruptured 3 balloons at 26 to 30 atmospheres, and then I put a shockwave in at 2 atmospheres and shocked it the whole 180 shots or seconds or whatever, and pulses. And then I literally inflated it at 6 atmospheres. The stent went poof and inflated. So I've never had that experience with pave and not be able to crack. So if anybody knows crack and pave or pave and crack data, please share that with me. And maybe gore or maybe a covered stent is different than a bare metal stent.
Yeah, the shockwave works great for that type of situation. And I'm disappointed you didn't save your shocks to play in the water afterwards.
I used the whole 180 pulses.
But we all want to treat the patient right. And I guess my question is, and I know what Eric is saying, 100%, we got to put the cost aside. But if there is another way, I guess your point is well taken. You can't predict which lesion is going to expand, which lesion is not going to expand. You might get it 9 out of 10, but that 1 out of 10 may be the disaster for you. That's a great point.
I would push this case even more and probably even shockwave that common femoral DCB it just because you're here. If you could get your surgeons to buy into it, and then finish that case off.
Well, if you saw Christian's lecture earlier, everything we do results in a bad outcome.
Yeah.
So, so anyway, all jokes aside, so what are you guys doing now?
We did the shockwave, and
sorry.
And we took a picture after the shockwave. I know what Dr. Jenkins is going to say. Didn't make any big difference. But I feel like now we're going to put an O35 catheter across and see if we're going to get a good path through. Initially, we could not pass the catheter across at all. We had to really push for it. So let's see how that works on an open 4 now.
And there's definitely some change.
So now the Navicross is already down. So we were actually easily able to get the Navicross across.
So the idea is now to just balloon dilate a little bit, get us luminal gain so we can get our
by putting a covered stent.
Down.
So
any thoughts?
I just have a question. I think the covered stent is a very good idea in the sense of that you've decided you're worried about rupture. I just want to, as you guys get the covered stent, don't tell me what you're doing. I'm just going to ask the panel. So gentlemen, I'm curious. You've done a shockwave which has modified this plaque. Why a covered stent? Why not just go with a bare metal stent? I'm curious because I know the answer is we don't know, we can't predict. But would a balloon angioplasty not do the same thing as a stent, or you think a stent can actually rupture the vessel while the balloon may not? I know these are anecdotal thoughts, but I think these are important thoughts.
Are you talking about covered stent versus like an OmniLink?
Yeah. Why not a bare metal? We've already done a shockwave.
No, right? I was going to ask you. So before you even start all this, does that factor in? Because if you already know that you want to use a covered stent, then why not use a specialty balloon and just go high pressure? You already know you're going to use a covered stent. If you're going to use maybe something else, then you shockwave it. Maybe you IVUS it now. And then maybe you think you can get away with a bare metal stent. I mean, if we're talking about
it's a good economics. No, but Eric, you gave the lecture with the co-best. You think it's the data that supports the use right now because it is a TASD?
Yeah, I mean, I think that lesion's risk of restenosis is high, and I think you want to deliver the best therapy here. So I think your covered stent, obviously, we worry about edge restenosis for covered stents, which is more at the distal edge, but I think where that was located in the lesion, a covered stent is going to give you a better long-term result, in my experience, than an open cell.
And also the data from the
And that's going to save my tax money because if you do one-stop shopping versus a second procedure, he's going to reduce repeat procedures by following the co-best data versus doing what you try to save money now. And then, the difference in cost between a covered stent now versus a complete another procedure, that's a massive cost difference.
That's a good point. The one question I do want to ask Raj, and I'm going to throw this out to you. If you look at the Bravissimo data, it was Mike Jaff, it did a great registry, core lab adjudicated. TASD lesions had a great result with Bravissimo. So you could say it's not randomized. So what quality of data? Does everything have to be randomized for us to say that is going to be our standard of care? Or are we going to be able to take a high quality registry and say, hey, listen, this is pretty good data to make a decision on? Raj?
I agree with you. I think not everything's going to be a randomized prospective trial. It's hard to do those things. I mean, sometimes those retrospective databases give you an inkling or give you an idea, like this may actually work. It takes years to do a trial. By that time, the technology's changed. Everything's moved on. So I think retrospective data sometimes does give you fairly decent data. I mean, there could,
Well, and Eric, I mean, it wasn't retrospective, Eric, because Bravissimo wasn't retrospective. It was a registry, but it was a prospective registry. Yeah,
exactly.
So what do you think about core lab adjudicated to make some decisions?
Yeah, I mean, I think that's the best way to do a single arm prospective study, in a non-randomized way. So I think, Michael and Vascor has done such a phenomenal job augmenting our data to do that. I think, again, it's all about what question you're asking and what's the likelihood of you getting an answer. And we can see, we saw earlier from Tomas's, and femoral study that it's hard to randomize patients, get stalled. We saw what happened with COVID. And so I think we need to find the alternative data, which is probably that's next in line, so.
The reality is that you ask that question because cardiologists are spoiled, because we have more randomized data than any other field.
That's true.
From the beginning of time. You can listen to Ron Waxman talk about that. But so you can't use randomized data to make all our decisions to do everything we want to do. And we have to take surrogates and we have to extrapolate. I mean, why do we use dual antiplatelet therapy in any program? We have zero data. We extrapolate off of this coronary data that cardiologists came up with or TAVR. I mean, on and on and on. You can say it. So, yes, we have to accept surrogates at some point, but yes, we have to try to strive to use randomized data when we can, when it's reasonable. But, money's the bottom line.
That's a great point.
And time.
There's a question, guys. Franny?
I don't know if it's on. I'll just yell. I have a loud voice. But what did you guys do for stents where you couldn't get full expansion before Shockwave? Because I don't see it that often that I can't get a stent expanded, even with a covered stent. So why not, like PK say, you go with a VBX and be done? I'm just curious what people were doing before.
80 fluence and rate with a laser was the best we had if the vessel would accommodate something that size.
Orbitals, people take an orbital up, they're also orbital atherectomy and use that in unique situations. Again, I don't love that, but
yeah, I mean,
fly when you do that.
Yeah, I mean, I know you showed me a case where you did it, Dr. Jenkins. But okay, Karthik, Vishal, now I see the stent in place. You haven't told us what it is yet. Yeah. The question: how did you? Now you had a post-stenotic dilatation, right? So at least in the angiogram. So explain to me, when you're using a covered stent, you theoretically want to seal proximally and a seal distally, right? Because you're worried about rupture. That's one of the reasons you're using it among other than patency. So tell me how you size this stent and how you're gonna, and why you chose the stent that you chose.
Okay, we measured it through IVUS, of course. That's why we IVUSed it. I think IVUS gave us a lot of information. I think just distal to the lesion, I think we got 9.2 as a diameter. So I think below that is almost 10 as a max diameter. So I think when we go closer to the lesions, that's why we took a 37 stent. So the sizing was the issue. So we took an 8.0 here because we were able to use a 6.0 balloon and we thought 8.0 is fine. 8.0 can go up to 10 if necessary. We have to do it. So I think 8.0 can even go up to 11 if I'm not wrong.
11.
So there will be some foreshortening, but I think I think we can take that foreshortening because it's a 37 stent.
So which
I guess the advantage of
so we took an 8.037 live stent.
Okay, live stream. Okay, so can you just tell me a little bit about the differences? I mean, actually, once you guys deploy, as you guys deploy, I'm going to talk to our panel here, and especially.
So that's what I was going to ask you guys, PK. I was going to ask the panel, what do they think about the position of this stent?
Okay.
So
before you ask about the position of the stent, do you think you should have a second wire down the other iliac just as a protection?
No, I think there's not much disease right there. So I think even if there's a slight pinch, there might not be enough to compromise my right iliac. My right iliac is pretty much disease-free. I mean, you can talk about carina having disease and to the other side, but I don't think angiographically it's that significant.
Well, Vishal,
there's a big hunk of calcium sitting there.
Yeah, but Vishal, in the last case, George Adams had a very difficult case similar to this, where he had a CTO and he had some calcium and he put a VBX in that case, and there was no shift to the iliac. So I agree with you. I don't think there is. Dr. Jenkins, would you?
But there's some. I'm not saying it's clean, but at least
I would not protect because I'm not concerned about getting back through that iliac.
Okay.
But I do think that there's risk of plaque shift into that just because it's an eccentric looking calcium hunk. Look at where your stent is laying. It's on the opposite side. So what you're going to do is you're going to push debris over there. But I would make it interesting. Deploy it first without protecting because you can always go back and rescue it.
Okay, well, you got it, guys.
Please, we have enough pressure doing this without PK in the room, so don't put more pressure on us. But I'm saying, so just to make it, Dr. Jenkins, I know the carina shift. I think that's what Vishal wanted to say. If you look at the IVUS, the ostium, right? The most of the calcium is actually right after the ostium, right at the ostium itself. So this is your ostium of the left common iliac. And when I pull it down, see, this is when it enters the aorta. If you really see the ostium, most of I don't think this shift is going to happen into the other side. We were more concerned about not able to cover this or not able to expand this. That's why we used a shockwave. But our concern is not about the shift at all. If you agree with that or not, I'm not sure. But
yeah, well, the shockwave.
I definitely wasn't born when you were doing this. That's for sure.
Well, the shockwave may very well prevent snowpiling plaque because you've ruptured the plaque into fracking therapy to it or whatever you want to call it. So you may not have as much of a mass effect once you've done shockwave. And I wouldn't worry about not being able to salvage it. I mean, you're experienced. I trust your experience.
So while they go up with the balloon, you guys go ahead. I'm going to ask Raj and maybe all of us who do a lot of these.
So PK, look at the eccentricity of the wire when we are actually ballooning this. So
that's always the scary part, right? When you have eccentric
and that's what Dr. Jenkins was saying. But I think you'll be fine.
But you can see on the balloon where the plaque is. And it's going to shift.
Absolutely.
Yes,
that's what we
know. That's right.
It is located towards this contralateral iliac.
But that's what he means by the eccentricity of the wire. Yeah. So Raj and whoever wants to chime in, Raj. I mean, you've got two great covered stents. You've got the LifeStream stent. You've got the VBX stent, right? Can you go through a little bit on both the stents because I know you've used both. We've all used both, but with your Nordics, you do a lot more. All these wonderful things. So can you tell me what the pros and cons or the advantage? I would say pros and cons. What are the pros and pros of both stents?
I find the VBX is probably a little bit more flexible. As opposed to the LifeStream. Now, if we're probably going to do a snorkel or chimney, we may not want something horribly soft. I find the VBX can be a little bit soft for that, so especially an SMA. We probably use a LifeStream or an iCast where you have a fair amount of radial force, you can't really crush it.
Right.
VBX would probably not be a good choice. So areas where I find that I want a little bit of flexibility, I find that the VBX is probably better. Here where it's fairly fixed, I think your option is probably both are probably reasonable, but maybe if you're going out in the external and you want to do a covered stent or expandable for whatever reason, then you may want to use.
We have a lot of room.
Right? So Srini, if you want to say you had a post-stenotic dilatation, you had a poor landing zone. I mean, do you find that the ability of the VBX to go to a larger, vessel
get a
size,
920,
to 11 or 12, or
and then
you take an XL up to a 16? I think is that part of your algorithm on choosing which stent?
Definitely, but also remember it has it foreshortens.
Right. So that's a great point for the audience. I mean, both stents are great stents, but they both have strengths and weaknesses. And I think it's important to tailor your therapy. This is a great example. I know Nick and a lot of others, like myself, we were big proponents of imaging, and you saw how imaging helped Dr. Gujja here. It was allowed him to actually be confident that he's not going to get plaque shift into the other iliac. So that's wonderful. So Karthik, great result. I saw the angio. Yeah. What are you doing now? I know you're trying.
So we are trying to get an A2 balloon because I know distally if you offload once. So if you actually see that's exactly what PK was trying to actually ask me the question. What am I going to do with the distal post-stenotic dilatation? So we're actually taking an A2 balloon, trying to get to the distal edge and make sure that we can expand it more. We're going to IVUS after the A2. And then we'll decide if the 9.0 is necessary or not.
Correct. Yeah, we want to.
That's our goal. Well, do you guys agree or?
No, I don't agree. I think you let Ajit or Dan or anybody when they do the cut down post dilated with the 9 because I think it's not worth going through the arm and risking any sort of other perforations going on. I think you got a great result. And if Ajit or Dan find a gradient when they do the endarterectomy, then or Pablo, then they can just do a balloon through the cut down. I think
that's exactly what our plan was, PK. That's why we're going with 8.0. See, the 8.0 itself looks pretty decent size.
Well expanded, so.
Yeah, and that's why we went with 8.0.
So I want the audience to know, like all the stents do expand larger than their diameter, especially VBX is also, both of them are tailorable. VBX comes in an XL, which allows you to really tailor the one portion of it even larger if you need to. So I think you need to know your equipment very, very well as an endovascular interventionalist to be able to do these difficult cases. Stiffness, like Dr. Malik said, and obviously the other characteristics of the stent. So, question, guys. Anticoagulation. We saw Dr. Olin give a great lecture this morning about all the latest and the greatest in terms of our other medical armamentarium, which is probably more important than our interventional armamentarium. I'm just going to ask the panel before I ask you. Are any of you changing your algorithm in terms of what you're using post-intervention for all patients, iliac, so on and so forth? I know Dr. Tamala asked when he was moderating, but I want to ask you guys as well.
I'll say the same thing I said there. Yeah. I mean, as a cardiologist and knowing these patients and having treated their coronaries and everything else, I think if you've got multi-bed disease, I'm more prone to changing over and using DOAC therapy.
What about if they just have isolated vascular disease? Raj, take it yourself. You have a patient with just isolated vascular disease, no cardiac disease. No, say they're a smoker but not a diabetic.
Yeah, I've actually gone to following the Compass trial and putting them on Xarelto for almost routinely now.
Okay.
So I wanted to ask George on his moving over to Compass on his coronary patients. So, are you going to do you use clopidogrel with them or?
No.
I mean, what do you do when you get them off ADAPT?
Yeah, so so for some of these complex people, now this is an iliac lesion, so I think you can do whatever you want. But let's just say it's more complex BTK type stuff. Then I will probably do Plavix and Xarelto combo and not aspirin.
We're slowly moving over to Compass, but I mean, change is slow, and so
I will say,
don't know what the reluctance is, but we're trying to do it.
I was an early adapter when Compass came out.
Let's take a picture.
It was 2 years ago. But it's shocking now the number of patients who are coming back in and telling me that other doctors are questioning why they're on this dose of Xarelto because A, they never heard of it, and B, they don't know why they're on it.
So that's a great question, but I want to ask Srini, because Srini, working in Florida, you have an elderly population, right?
Yes.
You're doing
high risk of bleeding.
Yeah, higher risk of bleeding. So are you adopting this? Because the data is pretty strong in terms of if you choose the right patient, your effective therapies really outweighs the risk of bleeding. So
definitely, we're taking the aspirin out.
Okay.
More and more data we're seeing now. And Plavix we use for 1 month. And then leave them under also 2.5.
Not yet. Excellent.
I'll make one comment. Mike Gibson, my partner, ran Pioneer, AFib, and some of these trials. They'll tell you that ticagrelor 90 milligrams twice a day is the same bleeding risk as Xarelto 2.5 milligrams twice a day. So just to keep in mind, I always tell when I give these lectures that the bleeding risks are probably not that much different from a more potent antiplatelet agent like prasugrel or ticagrelor versus Xarelto, which is interesting.
It's very interesting, and also you have such great data with this in terms of limb and cardiovascular. Unbelievable. Yeah. Okay, Karthik, we're back to you. What are you doing?
All right. So you came on time. So do you want just off?
We're going to show you the IVUS, right?
We're going to do the post dilatation picture. Me and Vishal were very happy with it. I don't know what the panel thinks. We were pretty satisfied with it, so we went for the IVUS. Yes.
I think the distal looks well opposed. The calcium is, of course, the right common iliac Dr. Jenkins was concerned about is still happy and alive. And the left side, the calcium is, we got through the ostium. So I think the position-wise and expansion-wise.
Yes, Dr. Atlanti, you had a.
And like PK said, you don't want to go crazy aggressive 9, 10, and then end up calling Dan or Rami or Raj early on. So I think we're just going to see a quick IVUS.
Yep, let's see the IVUS. Can you
so let's go live on the IVUS.
That's live.
Okay, that's live.
Okay, start recording. Beautiful. So that's the IVUS. That's your distal end.
So distal end.
Then go a little bit at the ostium. Show me the ostium again.
Yeah, right at the ostium.
Yeah.
Okay, that's exactly what.
Yeah.
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 We might go back and
so
the ostium.
We're planning to go back in with an A2 balloon right to the level of the osteum and go back a little bit more higher.
See, that's our bifurcation right there.
Yep. That's what Dr. Jenkins was pointing out.
Don't push that to the other side.
Yeah. You know what, guys?
Dr. Jenkins got it.
No, I'll be honest with you. I mean,
it's a very good point.
I mean, it's just a question here. I mean, knowing you're sending, this is me, and I don't know, you tell me if I'm wrong. I mean, you're sending the patient to endarterectomy. You've done a balloon angioplasty here. I think those guys can look at a gradient during the endarterectomy. If they find a gradient, they can go ahead. Raj, what do you think? Do you fix it now, or this is not going to close? It's not going to close. We all know that.
That's when I'll change it.
So Vishal, what do you think about that idea? Or you want to go ahead and balloon and make it perfect?
I think it's, you're right. Perfection, you can sometimes end up in trouble. But I mean, the idea is to just, if we can get with an A2 and just do one more expansion, a little bit higher gradient than what we did. And then I guess we just stop right there. Again, we're running after perfection. We don't want to get into trouble. So I completely agree with you.
But you're still going to go with an A2. It's like what we used to say to Dad. Dad, you're absolutely right, but I'm still going out.
Yeah. Exactly.
Friday.
Unfortunately, I'm right by his side, so we already made the decision. I'm sorry.
So it's at the end of the day, it's 4:50, and I don't think there's any problem. And it's Friday. I don't think there's any problem with leaving this alone and letting it remodel. And then you can go back from the common thermal at a later date, even though it's at excess cost to my tax money, and you can have all your options available to treat that osteo.
So I'll buy you an extra drink, Dr. Jenkins.
Yes, Dr. Jenkins, we're going to get you an extra drink tonight, Dr. Jenkins.
No, but I got to tell you, all jokes aside, I think for everybody who's doing this, I mean, it's a very important point. You know, when you have some other things going on, because let's talk about bailouts here. Eric, Srini, Peter, Dr. Jenkins, as well as George. I mean, you're from the arm, right? You don't have any other access, right? You're not going to be able to put up an aortic occlusion balloon. You can balloon tap it out the iliac, definitely, with the balloon that you ruptured with. But what if that rupture extends into the aorta? Eccentric plaque, right? Raj, I mean, why don't you comment? Because I know you've dealt with aortic ruptures. Tell us about that.
Yeah, I mean, you're going to have to get groin access immediately and, be able to flip out for an aortic occlusion balloon, and then you need to decide how you're going to fix this. Whether you want to try getting in, stent graft off. It's going to be tricky. Right at the crotch. You have a rupture.
No go crazy.
Oh, so you got a covered stent on the other side. Yeah, it's a big deal. So so Raj or Eric or whoever, it doesn't really matter. What equipment do you guys have in your labs for bailouts such as this? I mean, Eric, tell me what you have.
Coda balloon, covered stents.
And what sheet sizes? What sheet sizes?
I mean, that's the thing. I mean, I do most iliac still from the groins with an 8 French sheath, and I just angio-seal it. So that's been my approach. And again, I probably in this case, just starting from the beginning, I probably would have taken the 7mm shockwave here, which might have saved us a little bit of this waste. Again, I think if you're going to 2 to 4 atts and a 7mm balloon, you're going to be safe. And
especially using an 8mm covered stent. You could have got.
But that's also if I was going and I knew that I exactly covered stent and I already had on the table. Makes it a lot safer. Let me give you the risk. You don't have that type of bailout. You have that tiny groin access to get in trouble.
Yeah, Eric, did you say you had 8 French compatible aortic balloon?
No, we just have it in the lab.
Okay, yeah. So we routinely keep the heavy duty aortic stuff in the hybrid, but we have shocks that go through 8 French. So we can do it.
Well, I just wouldn't get overly aggressive striving for perfection, even though there's about 50 people watching what you're doing, just because you don't have all these bailout options you're mentioning available to you.
And then plus these patients going for a surgical cut down. So if they need to do it, then they'll do it.
Right. Now we're just going to show you the final IVIS and pictures, and we'll be done.
Easy.
I prefer a picture over IVIS because then we're going to chase it. Well, let's just do a picture. Now. Let's just do a picture. So
yes, picture it is.
Yep.
Yeah.
Nice case.
Please don't show us the IVIS.
No. Well, listen, we want to congratulate all of you.
At the osteum, so
great work.
It looks really, really good. All jokes aside, I mean, these are real decisions and realistic decisions that we're trying to help you with because we would be thinking the same thing. I mean, we want to make it perfect, but it's not necessarily a reason to make it perfect right now. You've alleviated a 90% lesion and left it at 10% or 5%. So I think you're fine. So your patency is going to be great. So thank you, both of you. Thank our team at Sinai for the great work.
Thank you, PK, for letting us do this. Thank you, Dr. Jenkins.
Thank you, everybody.
Thanks, you guys.
Thank you, the panel. Thank you so much.
So with that, we're going to end the day.